Evaluation begins with a thorough history and physical examination. The patient's history should be carefully reviewed for the presence of coexisting syndromes or chromosomal anomalies like charge, factorial, and 22q11.2 deletion syndromes, such as DiGeorge or velocardiofacial syndrome, which can have significant implications for the anesthetic management. Many syndromes are associated with airway abnormalities, difficult vascular access, or metabolic problems. For example, DiGeorge syndrome, frequently seen in patients with tetralogy of Fallot, predisposes to immunodeficiency and hypocalcemia. In addition, potential episodes of recurrent cyanosis have to be thoroughly evaluated, especially frequency, timing, and triggering events like agitation. Although echocardiography will provide the most comprehensive information about the nature of the cardiac defect, the anesthesiologist will need a clear picture of the preoperative clinical status of the patient, including typical behavior and tetralogy of Fallot symptoms during stress and pain. During the physical examination, the general appearance should be assessed in regards to baseline irritability and obvious cyanosis. The facial features have to be carefully examined for any evidence of syndrome or potential difficult intubation. Velocardiofacial syndrome can present with micrognathia. The auscultation of the chest should focus on the baseline respiratory status and any evidence of aspiration. The typical machine-like continuous murmur of a patent ductus arteriosus is expected, if not hoped for, in a neonate with severe tetralogy of Fallot. The vital signs should be noted. With the PDA present, the oxygen saturations should be in the high 80s to low 90s. The remainder of vitals should be normal in a non-agitated infant. A low diastolic pressure can be a result of a significant runoff via PDA. Blood pressure gradients between the upper and lower extremities, or pre- and post-ductal saturation differences, can indicate additional defects or problems. Preoperative assessment of the hydration status is extremely important. Tetralogy of Fallot with pulmonary shunting is a preload-dependent cardiac lesion, especially in the presence of a dynamic component. It is crucial to assess skin turgor, capillary refill, as well as the presence of a sunken fontanelle. Any obvious dehydration should be immediately corrected to decrease the risk of a hypercyanotic spell during induction. Finally, is vascular access present? Note the type and number of access points. Any current or recurrent medications should be documented and assessed for effectiveness. Neonates with severe tetralogy of Fallot and significant hypoxia are often started on a prostaglandin infusion to maintain ductal patency and improve pulmonary blood flow. The patient should be evaluated for the presence of a PDA murmur and improvements in oxygen saturations. Occasionally, an echocardiogram may be necessary to document ductal patency. Vasopressors may have been used in the form of continuous infusions or single bolus during episodes of sudden desaturation. Due to frequent and severe desaturations caused by agitation and irritability, the baby may already be sedated with narcotic or dexmedetomidine infusions. Any current antibiotic therapy and the last dose should be documented to avoid accidental double dosing and toxicity. Routine evaluation with a comprehensive metabolic panel, complete blood count with differential, coagulation studies, and type and screen are necessary. Preoperative hematocrit and hemoglobin are especially important. In the setting of cyanosis, elevated red blood cell counts are the primary compensatory mechanism to guarantee adequate oxygen delivery to the tissues. Unless the delivery was traumatic, neonates have elevated hematocrit values in the first days of life and are relatively protected. Maintaining a baseline ECG is a routine practice preoperatively. Arrhythmias are not expected with unrepaired tetralogy of Fallot preoperatively, but are quite common after repair. One example is junctional ectopic tachycardia. Chest and abdominal X-rays are typically obtained and can provide some insight to the pulmonary status, heart size, and location of the aortic arch. The preoperative transthoracic echo will define the details of the cardiac defect. The morphology of the right ventricular outflow tract obstruction, the gradient across the outflow tract, the exact location and number of obstructions, subvalvular, valvular, or supravalvular, and the presence of a dynamic component. In addition to right ventricular outflow tract obstruction, other important findings are ventricular septal defect and assess for potential additional atrial septal defects or muscular ventricular septal defects. The size and function of the ventricles can be determined as well as the anatomy of the ductus arteriosus and the gradient across the PDA. It is also important to look for the side of the aortic arch. A right-sided aortic arch is common in tetralogy of Fallot and can have implications for the surgical approach during thoracotomies. In addition, the coronary anatomy and other cardiovascular abnormalities, such as an aberrant subclavian artery or a vascular ring, can be evaluated.